I've been asked so many questions about COVID-19 and PPE requirements. There is a lot of information out there and it's hard to know all we need to do. Even if we don't know everything, I am passionate about the fact that there is so much we do know. And now, more than ever, as a profession, we need to be confident in who we are and what we do for our patients. So choose to be optimistic for your patients. You all will set the tone. Your optimism will help your patients feel comfortable to move ahead with treatment. I will answer my most frequently asked questions. My answers are what I have researched as of the date this video was produced. The important thing is that you make sure your team is following the CDC, OSHA, and ADA guidelines for your patient safety, risk management, and regulatory compliance as they are updated. And I hope that all three of these organizations will continue to update protocols as COVID-19 evolves and we get more data all the time. So question number one is it even safe to go back to work? Linda Harry, a licensed healthcare risk manager and well-known regulatory compliance expert with over 30 years of experience in providing quality assurance, patient safety perspectives for dental health care professionals and state licensing boards. She said in April of 2020, "Yes, I think it's safe to see patients today, provided we have the proper PPE." I personally agree with Linda, especially if you are young and healthy. The most questions that have come to me have to do with what is the proper PPE? I've looked into this extensively and my go-to source has always been Gordon and Rella Christensen, both of whom are world-renowned experts in dental materials, both co-founders of clinical research that was founded in 1978. Rella and I serve on the Utah Valley University Dental Hygiene School Board together, and they both have been close family friends for years. Question two, what kinds of things, including PPE, should we do to reduce the risk of transmission of COVID? Let's talk PPE first. CDC has recommended face shields, scrub caps, disposable isolation gowns, and shoe coverings. A lot of us haven't used all these things, including me, over the years. Now's the time to, especially during aerosol producing procedures, which, if you're using an air water syringe, is everything. Let's talk masks. The CDC website states that non-clinical personnel, yes, non-clinical personnel, can wear a cloth or surgical face mask, and clinical members can do the same when they are not actively caring for patients. The intention is to keep the wearer from spreading particles while they're talking and sneezing and coughing. It's not intended to be PPE. Those would be respirator masks N95 or level 3 masks such as critical cover or PFL masks with the magic arch, which are easier to get according to Rella and Gordon. They suggest clinical team members realistically wear these when working on a patient who has an emergency and has answered yes to one of the COVID questions. That's what Gordon himself is doing. Because they're really hard to breathe through. You get hot, they fog up. KN95 masks are a little easier to breathe through and a little easier to get. Ultrasonic scalers. This is such a bummer. I hand scaled a lot in the beginning of my career and nobody wants to go back to that. But Gordon himself says that during this COVID time, they are not using ultrasonic scalers. His wife and co-founder, Rella, has said an isolite and like products only reduce aerosols as much as a saliva ejector would. She and I have both pushed for hygienists to have assistants for years. So use an HVE when you go back to using ultrasonic scalers, and when you polish, you should be using an HVE. Counter disinfectants. Again, Rella is the bomb on this one. She recommends BioSurf bag in a box, kind of like a wine box. This will kill viruses in the presence of human protein in about 1 minute. And Germa X is also one she recommends, or Lysol 3 if available. But Lysol 3 has a 9-minute kill time. These are the only 3 brands that will kill organisms on a countertop and that meet the standards of the CDC. Currently, there are no pre-wipes that kill oral proteins. She says to safely disinfect, first, pre-clean the prepped area surface with a 4x4 that has been sprayed to the point that it's dripping wet. Second, leave the surface wet for 3 minutes and then repeat the dripping 4x4 spray and wipe to disinfect. Then if desired, you can use a paper towel to dry. All right, let's talk about air filtration. Rella also suggests that we all bite the bullet and invest in a good air filtration with high air exchange for the entire office. Operate at 24/7. ECM Phantom, a company called Gordon Cleanroom Products in Louisiana, has some that completely clears out the operating area over 50 times per hour. That's about once a minute, and that's what she recommends. Outerwear. Rella and Gordon recommend scrubs worn under a disposable gown, single-use and discarded, or single-use and sterilized that are washed on site, or professionally laundered. The wearer shouldn't leave the clinical site while wearing the protection. These are hard to come by, I know. Ideally, it would would be nice to have some disposable gowns right there by the hygiene operatory for your hygiene exams, but that might not be realistic. They do have a good suggestion. We could put a box or, a supply of them right by the hygiene rooms and then use one and then maybe sterilize that disposable gown, and the hygiene exam disposable gowns could be sterilized and reused. There's not a lot of aerosols going on in the hygiene exam, so that's a possibility of a way to use more and not need as much in this time where it's hard to get. So do the best you can. Leaders, owners, show your team you're willing to go to bat for them. Use as many supply people as you need to. Go in a dark alley and find some dealer to sell them to you so that your leaders and your patients know that you're willing to protect them and put a lot of energy into finding as many as you can. Pre-rinses. First, the patient should rinse for 30 seconds and spit it out into an empty cup, and then rinse a second time immediately following. The reason Rella says for 2 rinses is the first rinse will be soaked up by debris in the saliva. Then the second rinse will be your main source of antimicrobial activity. The second rinse would ideally be chlorhexidine based for a bacteria kill. The high ethyl alcohol based for viral kill rinse, Rella Christensen herself said, quote, "I am at a loss to suggest a high ethyl alcohol rinse, since most have been removed from the market about 10 years ago, when people thought they might be harming cells. There really is no antiviral rinse commercially available. It's difficult to become excited about a hydrogen peroxide rinse," she goes on to say, for several reasons. Number one, it's easily neutralized by mucin and other human secretions. And 2, many bacteria and red blood cells are equipped with the enzyme catalyst, which enables them to release this enzyme on contact with hydrogen peroxide and neutralize it. So for now, I think the bottom line is make sure your patient rinses twice and at least kill bacteria. Unfortunately, we also need to reduce patient contact as much as possible. And I have a few tips. Number 1, currently the CDC recommends actually talking to your patients, not just texting them when you're going to confirm their appointment. So verbally ask them at that time if they've been sick or in contact with anyone who has been sick, if they have been exposed to COVID-19 or have exhibited fever, cough, sore throat, shortness of breath, and have a loss of taste or smell. Some offices are also asking patients if they've even been in contact with anyone who has had those symptoms. Tip 2, use teledentistry for consultations, periodic exams, and post-op calls as much as possible. Make sure you're HIPAA compliant while online with a patient. Violations can be up to $100 per patient. Also, check your state laws. Some insurance companies will pay for teledentistry for 90 days during COVID. D99.95 if your teledentistry is done in real time. D99.96 if you're storing the information and forwarding it. Charge $14 to $44 for limited oral evaluation and code it D0140 or D0170 for reevaluation. In your chart notes, state method of obtaining the data, the video date and time, expectations of the diagnosis, and patient consent and location the doctor's at, whether he's at the office or the house. More tips. Limit who can accompany the patient to the practice. Ask patients to remain in their cars until they can be seen. Explain physical distancing measures that have been implemented. Remove your beverage stations and magazines and crackers and all that and other community property from the waiting room. And add hand sanitizer stations in patient-facing areas. Temperature checks for both the team members and the patients. Team members performing this should be wearing protective outerwear, such as a face shield and a disposable gown. Then be sure to disinfect your common areas and doorknobs and light switches. Question 3, what scheduling changes do we need to make? I've been looking for the CDC recommendations on this. I've seen a lot of different suggestions, like staggering patients to accommodate waiting protocols. Everybody should be one operatory part. If you're now staggering patients, what systems can you implement to reach your production and collection goals? What team members do you need in the office at what times? Those are things you all need to decide. Question number 4, how do I pay for all this PPE? This is a tough one. Hospitals charge for it, and I don't think the cost should cut into your team's profits. COVID's not anybody's fault. On April 23rd, 2020, the ADA urged third-party payers to alter their fees to account for increasing costs of personal protective equipment for dentists. The ADA statement advised dentists to develop a standard office policy to document the additional PPE that will be used across all patients and to add a note in the patient's record to document the details of PPE uniquely necessary for the visit and charge out using D1999. Teresa Duncan, dental insurance expert, says, quote, if you're in network, this should be a code that carriers would normally disallow, which means you can't even charge the patient patient. She had only heard that Delta Dental in Connecticut and New Jersey temporarily were reimbursing $10 per patient per visit for PPE. Quote, if you're charging for PPE, then consider creating a specific code to track it. Set up a modified code like D1999.1 or D1999.P. Only the first 5 characters will print on the claim form, and this code can be the code for infection control. This will help with the tracking of the charges associated with PPE, so you can run a report and know what you're doing and what it's costing you. Number 5, how do I deal with deliveries? Provide new instructions for UPS and FedEx and whoever else to keep your team safe. Delivery companies might even only deliver once a day from now on, so you might want to send deliveries to your residents on the off days so you don't miss deliveries of your much needed supplies. Question number 6, what if someone refuses to come back to work and they don't feel safe? My answer is this, and always has been, get professional HR support. I've always recommended that this be outsourced to a professional company like Cedar or Bent Erickson. Now more than ever, you need someone on your side to guide you through the rehires and possible hiring and firing issues during this complicated time of COVID. They will know your state laws, they will know what you need to do. I hope this COVID-19 FAQs class has helped you feel more comfortable getting back to work. Remember, like every other day, this is still dental practice. It's not dental perfection. Do the very best you can and improve every day. That's it, guys. If you have any questions, let me know.